Thank you very much. So it's again a great pleasure to join you again. And so this talk follows on very well from the last talk. I'm going to talk a little bit about how we regard AKI, particularly in the ICU, stratify its risk and determine what treatment we should be given and what new tools we have available to help us with that. I have some disclosures here. Most relevantly, I have had both some research support and some consultancy with bioMérieux and the Astute, who are the manufacturers of both NephroCheck and the NephroClear biomarker that I'll be talking about a little bit later. So what we have in terms of AKI is the KDIGO AKI classification, and there's certainly a lot of imperfections in this, but it is the mainstay of how we think about clinical management of our patients in the ICU, and it certainly relates strongly to outcomes, but it's important to consider exactly how patients' different sort of journey in terms of their renal function while they go through their illness reflects their actual risk of various outcomes, because KDIGO is just a snapshot, at least in the way we apply it clinically at the moment, and we really need to think about the patient's entire sort of journey of renal dysfunction. It's important to note that the original studies, such as those conducted by Eric Host and Marlies Osterman, that examined KDIGO and its predecessors, the Rifle and Akin criteria, were really using it to look, as many epidemiological studies have done, at the peak AKI criteria within the ICU, within the hospital admission. That would be, a stage 3 AKI or the old Rifle failure definition, which is certainly associated with the worst outcomes, and so severe AKI is definitely associated with risk of death. But it's pertinent to note that we can have a very severe decline in renal function when the patient comes in through the door, and they may be going through an earlier stage of AKI, and it's difficult to prognosticate both the severity of AKI and the likelihood of its persistence at that level, because the rate of rise of creatinine will be affected by things like muscle mass, potentially by some very acute manipulations in volume, and therefore the rate at which patients go through various AKI stages can vary according to their clinical condition, and indeed sicker, higher risk patients may have a slower rise in their serum creatinine because the factor is completely unrelated to their kidney, and we need to better prognosticate them, because it's really this KDIGO 3 area where the highest level of mortality is located, particularly in those where that is a persistent injury. And so it's more complex than just diagnosing AKI, intrinsic or tubular injury. We really want to know whether it is going to be transient or persistent, and the severity within that. And if there is persistent AKI, we need to have an idea about the patient's risk of recovery or non-recovery in order to better determine their long-term care. So these are really my sort of diagnostic goals when perhaps thinking about AKI. I would like to detect AKI precisely and promptly, but I would more importantly like to establish likely time course and perhaps its reversibility, which I would count as being its response to hemodynamic therapy. I'd like to detect etiologies to specific treatments. I'd like to determine its likely severity. So that means I want to know the severity of what's actually going on in the kidney at the time, rather than what's happening in the biochemistry right now, because the biochemistry right now will lag behind what's happening in the kidney at the time. But that's actually the injury that your patient is seeing. And I'd like to be able to meaningfully assess outcomes, risk stratify patients, and direct them to the appropriate CKD treatment or prevention pathways. So we've always known that there's this temporal as well as severity element to AKI. This is one of an early study by Stephen Coker, who was looking at a large cohort of US veterans with diabetes who underwent surgery as a sort of high-risk population. And what you can see here is not just the relationship between the AKI stage, but also the duration of the AKI. And you can see when we look at this sort of three-dimensional model here, it's actually the persistent severe AKI that has the worst outcome. So really, if you have stage 3 that's there for a day or two, but actually it goes away again, well, maybe that's a relatively small perturbation that is not reflecting very severe consequences within the kidney or for the patient itself. It is the AKI that is carrying on for a long time, and there, it is there when the level of severity has its biggest effect on outcome. And so it is persistent severe AKI where the mortality is at, and this is what we should be potentially focusing on. But of course, when our patients are there at day 2, 3, 4, when perhaps they've first been diagnosed with some form of AKI, we don't quite know what trajectory they're going to be on. We've reflected on this over the years, and John Kellum and his group have been particularly important in this, and they developed this sort of conceptual framework about 5 or 6 years ago now, looking at the timing of AKI reversal, the reversal duration, and the kind of the pattern of AKI during out the whole of hospitalization rather than just in the first acute episode, and looking at recovery status, but also reflecting on the fact that we're actually not very good at looking at recovery status, and that probably should be assessed long after hospital discharge, not just in hospital. And they did a study where they therefore looked at a very large cohort, and they looked at early reversal and then whether that was sustained, and in particular the group in the bottom left corner here with never reversal. And what they found, as you might expect, was a very clear relationship with long-term survival, and the never reversed group or the group with a relapse after perhaps the early potential recovery had by far the worst outcomes, whereas the early sustained reversal group have a relatively benign set of outcomes. And so certainly much better than the late sustained reversal, where it looks like there is still potentially some ongoing mortality risk, continuing divergence of the adjusted risk of death curves. And so from this, we kind of developed the concept of acute kidney disease as being very important. That would be the persistence of patients meeting AKI criteria beyond day 7. So they're out of the window for the formal diagnosis of AKI, bridging the gap to the development of CKD, not just from the point of view of diagnostics, but a point of view of pathophysiology in these patients. But of course, the AKI and AKD, as it were, can have very many different profiles, and this includes patients who perhaps never actually signaled with having AKI, but to get progressive decline in kidney function, you could draw many, many other different potential profiles, and so it's this strong temporal element that makes it much more difficult to risk stratify your patients. A number of other studies have looked at this. This is just one example. It shows that persistent AKI was certainly associated with much worse outcomes in terms of long-term mortality risk than transient AKI. It also showed that the persistent AKI with the worst outcomes was more likely to have a combination of both oliguria and serum creatinine criteria, perhaps as you might expect, reflecting its severity. And on this basis, John Kellum wrote an editorial accompanying that particular paper where he reflected on an approach to the patient with persistent severe AKI, a kidney damage approach, really consideration of the etiology of the AKI. Often these are less easily reversed situations, but it may be there's some exposure that hasn't been recognized that should be withdrawn, perhaps a drug-causing interstitial nephritis, for instance. There's the strong need to avoid further injury, exposure to unnecessary other nephrotoxins, a strong concentration on hemodynamic stability. Going alongside that, a need for monitoring to detect the pattern of change in potentially renal function and indeed to help you avoid further injury. A need to focus on drug dosing, not just from the point of view of nephrotoxicity, but on the point of view of avoiding the inappropriate drug dosing for the persistent derangement in kidney function. That may require other methods to actually properly evaluate kidney function in those patients. Serum creatinine may give us a misleading impression of the severity of kidney dysfunction, and we may need to use other methods to actually determine what the likely GFR is and thus dose our drugs appropriately. It may be time to reflect on goals of treatment, such as whether we may ultimately provide that patient with renal replacement therapy if they need it, or whether that's a treatment that is not justified, or perhaps one that the patient or their family might not want. and then we should be highlighting these patients as ones where it is particularly important that they have follow-up, both from the point of view of their renal function, but also their ongoing cardiovascular risk, which is strongly associated with the development of CKD and non-recovered AKI. So more recently, we looked at persistent AKI in our COVID-19 population. COVID-19, at least in the early waves, was associated with not just more AKI, but more persistent AKI, and indeed greater duration of renal replacement therapy. And so we had quite a large proportion of patients in our ICUs who had persistent AKI at 7 days, if they survived to 7 days, and that was associated with a very high odds ratio of further mortality in hospital, indicating the high risk of that population. This is some work from a group in Glasgow, and I examined this as part of a thesis. It's published in eClinical Medicine, where they looked at outcomes and patterns of acute kidney disease in a large cohort of Scottish ICU patients. And this is a nice paper because it just makes the point that acute kidney disease is more often associated, as you might expect, with more severe AKI, particularly stage 3, and stage 3 AKI is more slow to recover. And so really, when we're talking about acute kidney disease, persistent severe AKI, there's a very, very large degree of overlap. More of this phenomenon is severe than in the initial AKI. And acute kidney disease is strongly associated with, over many, many months after discharge, a increased risk of major adverse kidney events in terms of late mortality, end-stage renal disease, or significant deterioration in underlying renal function and the development of chronic kidney disease. So how can we kind of identify those patients who have or are going to develop persistent severe AKI and apply treatment strategies to them? Well, as we heard, we may need better diagnostic tests. Creatinine may be late to illustrate the fact that there have been severe decrease in GFR, and creatinine in its own right has no insight into the severity of tubular injury. It is a marker of glomerular filtration, and therefore it can't tell you the rapidity of recovery. And so the investigators behind the TIM2-IGF-BP7 NephroCheck biomarker went on to perform some further studies supported by the industry who are developing those biomarkers, particularly the Ruby study, to look for markers that would tell us about persistent severe AKI. So here we took patients with AKI stage 2 within 36 hours, and they tried to determine whether they developed persistent severe AKI, and this would be them developing stage 3 AKI within 48 hours if they didn't already have it at enrollment, and that stage 3 AKI criteria persisting for over 72 hours, or them getting dialysis or dying within that window, which would sort of fulfill the same criteria. These studies were funded by Astute Medical and bioMérieux, and we have to acknowledge that again here. And what they found in this study, again looking at a number of potential candidate markers that were evaluated from the urine samples that were made available, they identified this CC motif chemokine ligand 14, CCL14, which was the most predictive of the persistent severe AKI, with an AUC of 0.83, certainly performing much better than the both injury biomarkers indicative of early AKI, such as NGAL, or filtration markers such as cystatin C or proenkephalin that would just be reflective of GFR. CCL14 is a chemokine, and it was recognized for roles in lymphocyte chemotaxis in tissue injury and repair, and it's been shown to be important for monophage macrophage recruitment, pro-inflammatory chemotaxis in a variety of inflammatory and autoimmune diseases. And so we're looking for the CCL14 and its potential role within persistent severe AKI. and what the thought is that this is reflecting the biological process of the infiltration and differentiation of inflammatory cells, which will be resulting in persistent inflammatory state within the peritubular environment, and eventually, if unchecked, the development of interstitial fibrosis potentially. And therefore it's a kind of a indicator, it's a window onto what the actual molecular biology and cellular biology is happening within the kidney at the time. What we need to know is perhaps how to use this tool, and so some further analysis were done by Jay Coyner and other colleagues, really to establish kind of cutoffs of this biomarker. And this paper was recently published in Kidney 360, and it shows that the majority of patients who developed persistent severe AKI had a significant elevation, and you could kind of, that population was reasonably differentiated from a low-risk population and could also be grouped into a much higher-risk population. And so there's this cutoff of less than 1.3, 1.3 to 13, and 13. And what you can see is that the increase in the outcome in these between these groups is mainly driven by the increase of the number of patients needing renal replacement therapy or having the persistence of stage 3 AKI. Death is somewhat a little bit superimposed on the top of this, and it's probably indicating this is quite a kidney-specific process. And so what we have is a low, medium, and high-risk bands, and these are associated with these differential cumulative incidence of kidney replacement therapy or death, but very strongly predictive in the kidney replacement therapy. And recently I've been involved in some further analysis of the CCL14 data, both within the Ruby study and then actually going back to some patients within the original NephroCheck Sapphire study, but looking at sampling from the point that they developed stage 2 AKI to get some further CCL14 data from those banked samples, and then to look at how these levels worked and how changes in CCL14 over time within the levels a reflected outcome. And so we really looked at the early time course, the couple of the first, second, and third measurements, and then a little bit of work on some later measurements. And so this was in 417 patients, and of which 75 developed persistent severe AKI. And the initial CCL14 levels were mainly distributed between low and medium, with a much smaller group with the high level. And the CCL14 category strongly correlated with the primary endpoint. Now, I've said here in the majority of cases the category unchanged from first to last, so in 2/3, which is good because it means you can have a reasonable confidence in the first level is telling you something important. But it also means in a third of patients the category did change, and we say, well, what is the meaning when the category changed? And this is this data. So initial low, the lowest risk is obviously it remained low, but if it increased, then actually you are moving into a significantly higher risk category compared to the no change. With the medium, again, the changes could be in both directions. If it decreased again, you were coming back much more into the very low-risk group, whereas if it was the increase in the biomarker, you were coming much more into the risk associated with the high risk. If you have any exposure to a test with the highest level of CCL14, that was really associated with a very high risk of persistent severe AKI, but particularly when it didn't change. And so really, particularly in the medium category, a repeat test would appear to have some good indication in the trajectory of the patient, which kind of makes sense because this test is reflecting the degree of inflammation that's happening in the kidney at the time. That could obviously get worse or get better. And if it gets better, then presumably your kidney outcome will get better, whereas if it persists or worsens, then things are probably getting worse for you. And so what we then looked at in some analysis is we controlled for the initial level in terms of risk, and we found that an increase or decrease in category was strongly associated with modifying the additional risk. And this alluvial plot here really sort of demonstrates how the things would happen in terms of a change in CCL14 category in the last CCL14 category that was measured for a patient, and that could be up till 7 days in the ICU. And what you can see here is that while a number of patients maintained in a category initially, what we found was that patients who were going to do well, eventually the category decreased, whereas if increases in category occurred, then that was leading people more into the adverse endpoints of death or RRT, and particular risk in this group remaining in the high category, particularly of requiring RRT eventually. And so, you know, quite useful here, and certainly indicating in this diagram the utility of repeating a medium level if you saw it on the first test. So, correlation occurred with the initial level, but where changes occurred, those strongly are correlated with the continuing risk of persistent severe AKI. You could have some confidence in prognostic interpretation of a single result, but serial measurement might reveal dynamic pathology and help refine prognosis over time. So then the question is what to do with this information. Well, what we should be doing with this information is we've actually been able to identify a patient who's going to have a persistent problem with their kidney and has significant underlying inflammation in this kidney relatively early. And so there's an opportunity to avoid harm, certainly. There's also an opportunity to have an enriched group of patients where we might be able to trial specific interventions and find that they work because we're applying them early enough in the disease process. And also there's the opportunity to adopt targeted follow-up and perhaps apply some specific secondary prevention strategies in the follow-up. And again, we'll go back to this DAMAGE acronym. This also gives us the opportunity for earlier in the time course, at the time of diagnosis of stage 2 AKI, to really think strongly about the etiology, avoid need for third injury, make sure the patient is being adequately monitored, consider our drug dosing as well as our nephrotoxicity, consider early on what our goals and ceilings of treatment might be, and to ensure these patients are directed into an adequate follow-up pathway. And with that, I'll conclude. Thank you very much.